which has prognostic implication, or significant anatomic proximal LAD, which has significant prognostic implications, or you are in the middle of the night doing a STEMI, or for that matter, non-STEMI, and those have significant prognostic implications. Whatever we do, we'll have to think about how we achieve the best results when we do the percutaneous coronary intervention. So yes, we'll have to go by the clinical, how the patient does, and we need to assess before and during the procedure. And also we look at the traditional tool, which is the angiographic reliance on the procedural success, and how we can still incorporate that into our decision making during the index procedure. And then we discuss more about how we can improve the PCI outcome by assessing the PCI that we just performed in terms of physiologic assessment and anatomic assessments, because maybe we need some kind of assessment to determine the best outcome. So this is a cartoon showing that there is an incremental value when we add further tools in our percutaneous coronary intervention assessment, in terms of from basic baseline clinical to a vigilant angiographic post PCI pictures, and then add tools like physiology and anatomy, then we get the best results. IVAS, or intravascular ultrasound, or now we are using optimal coherence tomography. For the discussion purposes about anatomic assessment, we can find out how the coverage of the plaque with the stent, how much plaque burden we have been able to take care of, whether there is any complications, and we can then decide, are we doing the optimal PCI or it is suboptimal? Clearly, the suboptimal PCI has worse outcome, and this is being shown here from a paper from 2018. Now, if you look at further, then the optimal PCI, if you use IVAS, and then by using the IVAS, you are able to do the stent expansion, take care of the problem residual stenosis, then the outcome is most favorable. And it is no surprise that in case of left main, the IVAS guided PCI, the difference with angiographic guidance, IVAS has clearly the benefit, not only for the intermediate term, but also for the long term. So that one procedure that we did years before, and it is guided by imaging, it has significant implications, particularly if we do the left main when it is a bifurcating left main PCI. And there are formulas, and we follow the guidance with the area. But the bottom line is that the name of the game is that we want to ensure flow. We therefore need to assess the physiology and whether there is any residual stenosis that can still affect the flow, and we can assess by fractional flow reserve or IFR or QFR, or we just go with the imaging and make sure that stent is expanded, stent sizing is good, and there is no edge dissections. But the question is, as we talk more and more about taking science where it is needed and heart care everywhere, we also need to pay attention that when we need this and when we need to be more rigorous, and what is the cost benefit, what is the availability, and whether we have the proper education and training to utilize these resources. These are important issues. So physiology only after the PCI, there is a difference. So those who are following the physiology guided with the fractional flow reserve, and many studies now have correlated this with the IFR also, or non-hyperemic pressure ratio, clearly there is an advantage when you can correct the problems identified by the post-PCI physiologic assessment. Question now is which one we should do? And this is one paper from a year ago that was FFR flow physiology versus IVAS. And basically it was neck and neck, and it was very competitive in terms of assessing the outcome over 2 years, almost no superiority on one over the other. So then in the FFR REACT trial, they looked at if the FFR is less than 0.90, maybe in those cases we use IVAS more aggressively, but even in that, there is no significant difference. And this came out only recently that in all comers, the FFR and IVAS probably would be same. Caveat is that these are all comers, many of them are simple lesions. Can we use this in the complex PCI? And if it is, then is it better that we do imaging? And what definitions we are going to use? The PCI, post-PCI FFR 0.88, or maybe in IFR, we don't sit on the fence like 0.9 or 0.91. Maybe we should be in the safe zone, 0.96 or 0.97 in that range. And maybe we achieve an improvement in FFR more than 0.05, or use the anatomic definition that minimal stented area of 5.5 or more. Or we make sure that the distal reference segment area matches. And Dr. Narula point out that, this is not only this, whether are we changing the plaque composition, and are we able to alter the plaque composition so that our delivery of devices giving us enough room so that we can come out good with the PCI. So these are all important issues. And I'm going to go through a series of cases and share the thoughts with you. One of the important points I would like to mention that in the anatomic world, we use the cross-sectional area, but maybe we should think about the total stented volume area or total interventional volume area, because the arterial lumen and the flow is dependent on a 3D, and we just should not look at a focal area. We should look at the total interventional the segment as a volume. And as Morton is not here, we have discussed this so many times that it is not just an ostial LAD or ostial OM where we see significant stenosis, but the flow wire giving us some sense that it is not in the ischemic zone, whereas in a long lesion, you see intermediate lesion, but that becomes readily positive because the volume area, the volume stenosis is really significant. So you have one case here that shows that acute coronary syndrome, and then circumflex OM we stented, and then we bring back the patient for the ostial LAD, and an interventional OM is done, and then ostial LAD is an important location, and we do this, and then we see that the area looks a little worse. When you look at a caudal view, I did 2 flow wire, and then OM circumflex FFR was good. The IFR on the LAD was 0.90. We did FFR and it was grossly positive. Then we do the intervention and then make sure that the interventional procedure is done. And I did not use IVAS. There was a significant improvement in the IFR and then we stop there. And then this is another bifurcating lesion. We talk about bifurcation and strategy. Should we do one stent or two stent? How we assess this? These are important issues. And if we can save a stent and then see the focal stenosis following this, we have a backup plan for bailout. But if the IFR is good on the diagonal, probably we don't need another stent. So this is another patient with a 41-year-old with this RCA. Look at the significant changes in the remodeling, as Dr. Narula was mentioning about the Glacob's remodeling in terms of positive remodeling without any significant luminal stenosis. But in the left system, there is significant bifurcating lesion. And we did the IFR both, and then used the bifurcating stent technique, and then came out good with just the IFR assessment on both. And so far, the patient has been doing okay. So this is another important example how the ostial right with the mid RCS significantly and geographically stenosed. And then we look at the left system, also equally bad. We were lucky to get the intervention done with the assessment with the flow wire. Now we are in the LAD, and we thought that the physiology alone may not be good enough. So we did the IVAS, and then we did the plaque modification, considering the significant calcification and fibrosis, and then we go with the preparation of the vessel so that we can come out good. We mean that the stented segment then reassess both by anatomy and the physiology, and then we hope that the long-term outcome will be better. So when we talk about this kind of lesions, then we always wonder what about trifurcating lesions? And I am very comfortable now with the using multiple flow wire, and use that as a guidance for determining which one we should do and which one we should leave alone. But things may not be that easy all the time, because patients may come in a different way. And this is something that patient came into us, cardiac arrest. We don't see any flow in the left main, and we rapidly unload cardiogenic shock. And then we try to do PCI. Question is, I don't think that we can use comfortably only the physiology in this setting, and it may beg further assessment by anatomic assessment in this kind of situation. So pre-post procedure, we need some kind of anatomic definition of stenosis, the physiologic assessment of ischemia, and also, as we are learning that more and more, we need to assess the plaque composition and have an idea about the natural history of the lesion. But I would request you, and probably request Dr. Narula to also add that where is the lesion? Is it a distal OM or diagonal, or is it a left main or proximal LAD? Because of the Duke database and from the CTA coronary the studies, very, very similarly showing that left main prox LAD has significant prognostic implications. And it is important to know the patient. So it is the patient preparation and also the vessel preparation, the lesion preparation, and also complex coronary. And this group defined the complex coronary, as you can see in the left, the bifurcating lesion, unprotected left main, implanted stent length more than 38, multi-vessel instant stenosis, significant calcific lesion, osteal lesions. These are very important issues where the investigators looked into this angiographic graphic guidance by PCI and imaging guided. And then clearly there is an advantage with the IVAS and OCT. 75% time they use the IVAS and 25% with the OCT, the similar. And when they use this and then were able to do the further stent expansion, take care of the problem, the outcome was the best. So physiology is important, anatomy is important, clinical context is important, but also we need to make sure that we are familiar with these tools and use this in our favor to rectify the issue as we identify this availability and cost. And when we do all that, then patient oriented composite outcome is going to be better, and that what we look for. And it is important that we do the procedure, so that procedure determines a lot of events downstream, and we also take care of the measures that we all should do, is the secondary prevention, as pointed out by our national professor. Thank you.